Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. Please be seated. May I ask why you have come to see me?
Well, I have had a sudden onset of pain by lifting a weight of about 40 pounds at my workplace. I have developed pain on my left hip. Although the pain is dull, it is aching and stabbing. The severity ranges from mild to severe. The pain is present constantly and worsens while sitting, twisting, lifting, or riding in a car. The pain improves after resting. Sleep alteration due to pain is positive, and I wake up after getting to sleep. I'm feeling depressed all the time due to this persistent pain and have lost my interest in all activities. I get insomnia, lack of concentration, fatigue, and loss of energy.
Do you have pain on your spine?
Yes, doctor.
Your age?
48, doctor.
Are you attending your work?
No, doctor, I am not going to work.
Have you been immunized before?
Yes, doctor. I had flu vaccine 2 years ago and pneumonia vaccine 5 years ago.
Do any of your family members have a history of illness?
My father is 79 and had a cerebrovascular stroke and hypertension. My mother had a congestive history of heart failure and died at the age of 70.
Tell me if you have any past medical history.
I had an appendectomy 7 years ago and a cholecystectomy 3 years ago.
Do you drink or smoke?
I used to smoke before, but I have stopped smoking nowadays, and I drink socially.
What medications are you taking now?
I am taking Lortab 10 milligrams whenever I get pain.
Are you allergic to any medication?
No, doctor.
Well, your MRI shows small central herniated nucleus pulposus at L4/5, bulge at L3/4. There is a shallow left parasag, herniated nucleus pulposus at L5/S1. There is an entrapment of the superior gluteal nerve in the aponeurosis of the gluteus medius left, and you are also suffering with depression and sleep disorder. So I would recommend you take a treatment for superior gluteal nerve block left. I am going to prescribe you baclofen 10 milligrams before bedtime, flurbiprofen 100 milligrams twice a day, hydrochlorothiazide 25 milligrams once in a day, and Klonopin 0.5 milligrams before bedtime. Continue these medications for 3 weeks and meet me thereafter for a scheduled follow-up for medical management and reevaluation of your condition. Depending on your condition after 3 weeks, I will decide if any diagnostic or therapeutic intervention is required or not.
Okay, thank you, doctor.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. Please, be seated. May I know your problem?
Well, I feel that I have jaundice and a pancreatic mass. And recently I've noticed a new murmur, bacteremia, and fever.
What's your age?
64, doctor.
Okay. Do you have a cardiac history, or else any shortness of breath called orthopnea, or attacks of severe shortness of breath and coughing at night called paroxysmal nocturnal dyspnea?
No, doctor.
Are you getting chest pain, palpitations, or syncope?
No, doctor.
You have any past medical history?
I had diabetes, hypertension, and transient ischemic attack long back.
Okay. What medications are you taking?
Acidophilus supplement, cholestyramine, Creon 20 3 times daily, Diovan 160 milligrams twice daily, Lantus 10 daily, Norvasc 5 milligrams daily, Novolog 70/30 10 units at noon daily, Pamelor 15 milliliters every evening, vitamin D3 1 tablet weekly.
Are you allergic to any medication?
I'm allergic to codeine, Coreg, and vancomycin.
Is there any family history of illness?
While my daughter has a history of a murmur, my father died when he was 75 due to chronic heart failure.
Okay, well, your laboratory data shows sodium 133, potassium 2.8, fluoride 99, bicarbonate 31, glucose 75, BUN 12, creatinine 0.8, calcium 8.6, total bilirubin 3.2, AST 63, and ALT 43, white count 5.4, hemoglobin 9.1, hematocrit 26.6, and platelet count 128,000, lipase less than 10. Your abdomen CT diagnosis shows a pancreatic mass with biliary obstruction. Previous biliary stent is present. Your electrocardiogram shows normal sinus rhythm. There are no acute ST-T changes. Your temperature is 98.8, heart rate 96, sinus blood pressure 138/55, respiratory rate 20, and oxygen saturation 92%. You have newly developed murmur that has occurred in the setting of fever and bacteremia. You also have a pancreatic mass with jaundice, hypertension, hyponatremia, and hypokalemia. Take Diovan and Norvasc for blood pressure control. I recommend that you should undergo an echocardiogram. This will be to assess the possibility of endocarditis, which may be contributing to these symptoms.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Doctor, what about the new device that will ease breathing difficulty in patients with chronic obstructive pulmonary disease?
Decreasing the volume of lungs affected by emphysema or chronic obstructive pulmonary disease actually makes patients with the condition breathe more easily. If they take a breath, due to the lung capacity, it causes shortness of breath. When we take a deep breath in, if it is hard to breathe up there, this is called shortness of breath, which our patients often experience. Therefore, reducing the lung volume significantly improves the quality of life. The new device resembling a valve is used for achieving this, and this is being tested in the US.
Question 26. Now read the question.
Lupus is a chronic autoimmune disease in which the immune system becomes hyperactive and attacks healthy tissue, resulting in such as inflammation, swelling, and damage to skin, joints, blood, kidneys, the heart, and lungs. Normally, our immune system makes proteins called antibodies to protect and fight against antigens such as bacteria and viruses. However, lupus makes the immune system unable to differentiate between the healthy tissue and antigens, which leads the immune system to direct antibodies against the healthy tissue instead of antigens.
Question 27. Now read the question.
Microlaparoscopic pain mapping. At times, finding the cause for pelvic pain becomes very difficult. This is especially true in the case of pelvic scar tissue, endometriosis, fibroids, and other problems. In a pain mapping procedure, the patient is given some strong medication to make them sleep. After injecting local anesthetic medicine into the navel, the physician will insert a small bubble of gas inside the belly and insert a laparoscope of very tiny diameter inside the belly to look around. Another small instrument is inserted lower down on the belly and used to touch organs inside after the patient awakens. While touching the internal organs, the patient will denote whether the patient is getting pain when touching specific organs. For instance, if the endometriosis is causing pain, it will be tender while touching the organ with the instrument. Moreover, when the patient experiences pain on the right side, it is difficult to make out whether the pain is in the ovary or the appendix. Therefore, pain mapping could help figure this out and help the physician pick the exact procedure.
Question 28. Now read the question.
Gallstones are formed due to an imbalance in the composition of bile, resulting in hard stones that are made of pigment or crystallized cholesterol, or a mixture of the two. They can range in size from as small as a sand grain to as large as a tennis ball. One can have a single large gallstone, dozens to hundreds of smaller gallstones, or a combination of both small and large stones. There are two types of gallstones. Typically, patients with pigment stones have cirrhosis of the liver, biliary tract infections, and hereditary blood disorders, including sickle cell anemia. These are all conditions that produce too much bilirubin, of which the stones are made of. Pigment stones tend to be dark brown or black. Cholesterol stones are formed as a result of bile that is made of too much cholesterol or bilirubin and not enough bile salts. They can also form when the gallbladder fails to empty during the digestive process. They are usually yellow-green gallstones, which are the most common type.
Question 29. Now read the question.
Hello, doctor. Can you explain what are the different types of breath sounds?
Well, there are several distinct types of abnormal breath sounds. Crackles, also called rails, tend to sound like discontinuous clicking. Bubbling or rattling when the person inhales. Crackling breath sounds may sound dry or wet, and physicians might describe them as either coarse or fine. Stridor is a high-pitched, harsh, wheeze-like sound that occurs while breathing in people with a blocked upper airway. Wheezing noises are high-pitched and persistent that may sound like a breathy whistle. At times, wheezing can be loud enough to hear even without a stethoscope. A short version of a wheeze, called a squawk, occurs during inhalation. Ronchi are persistent, lower-pitched, rough sounds similar to snoring.
Question 30. Now read the question.
Hello, doctor. What is spastic cerebral palsy and how is it classified?
Well, spastic cerebral palsy is the common type of cerebral palsy that also accompanies nearly a third of other types of cerebral palsy. The damage is in the corticospinal tract or the motor cortex. This part affects the areas that receive gamma-aminobutyric acid that is an inhibitory neurotransmitter. Spastic cerebral palsy is further divided into types according to the areas of the body that it affects. In spastic diplegia, the lower limbs are affected with little to no upper body spasticity. Most people with spastic diplegia are fully ambulatory and have a scissors gait. They may also have other problems like hip problems, dislocations, crossed eyes, or strabismus. In spastic hemiplegia, one side of the body is affected, which occurs when injury occurs to muscle nerves controlled by the left side of the brain. Will cause a right body deficit, and when injury occurs to muscle nerves controlled by the right side of brain, will cause a left body deficit, vice versa. In spastic tetraplegia, all four limbs affected equally. These patients are least likely to be able to walk because their muscles are too tight, and they may also develop an uncontrollable shaking that affects the limbs on one side of the body that impairs normal movement.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Role of diabetes in the end-stage renal disease. Of late, diabetes has become the primary cause of end-stage renal disease worldwide. This is due to the fact that diabetes, especially diabetes type 2, is increasing. Approximately 45% of new patients receiving dialysis in the U.S. are diabetic. Early diagnosis of diabetes and early intervention are crucial to prevent the progression towards renal failure, seen in a significant percentage of type 2 diabetic patients and in many type 1 diabetics. The presence of microalbuminuria is the early clinical evidence of diabetic neuropathy, defined as the appearance of low but abnormal levels of albumin in the urine. The characteristics of diabetic neuropathy are a decline in glomerular filtration ratio, progressive increase in proteinuria, hypertension, and a high risk of cardiovascular morbidity. Therefore, the evidence of microalbuminuria should trigger diagnosis for possible vascular diseases and aggressive intervention to cope with all cardiovascular risk factors in diabetics type 1 and 2. The natural history of diabetic neuropathy progresses slowly over the years. In type 1 diabetes, microalbuminuria occurs after 5 years, and the end-stage renal disease develops in 50% of type 1 diabetics. Whereas type 2 diabetics has a more variable course. Very few patients with microalbuminuria progress to advanced renal disease. Without intervention, approximately 20% of patients of type 2 diabetes develop an end-stage renal disease. However, due to the increased number of type 2 diabetes patients compared to type 1 diabetes, the maximum number of patients on dialysis are type 2 diabetics. There are many factors which account for the pathophysiological of diabetic neuropathy. Primarily anatomical and structure changes in the kidney result in increased glomerular capillary pressure in diabetes, which is associated with hyperfiltration at the glomerulus. The next factor is the glucose that can increase the formation of advanced glycosylation end products by inversibly binding to proteins in kidneys and circulation. Over the years, these formed advanced glycosylation end products which stimulate the growth in fibrotic factors, contributing to overall renal damage. Thirdly, angiotensin II contributes to the advancement of diabetic neuropathy by narrowing the efferent arteriole in the glomerulus, subsequently resulting in higher glomerular capillary pressures. While diagnosing diabetic neuropathy, early investigation of glucose intolerance in diabetes to distinguish patients who are at risk for developing microalbuminuria is suggested, especially if they have other risks for type 2 diabetes, such as lipid central obesity, abnormalities, or hypertension. Therefore, the investigation of microalbuminuria presence should be performed at diagnosis in patients with type 2 diabetes, whereas in patients with type 1 diabetes, since microalbuminuria rarely occurs with short-term type 1 diabetes, the diagnosis should begin after 5 years of disease. According to the findings, the microvascular complications develop during the prepubertal period of diabetes. Therefore, clinical judgment should be demonstrated when individualizing these suggestions. The object of diabetic neuropathy therapy involves multi-clinical approaches. Tight glycemic control is the keystone in the prevention and management of diabetic neuropathy. The United Kingdom Prospective Diabetes Study and Diabetes Control and Complications Trial have established that an intensive diabetes therapy can considerably decrease the risk of microalbuminuria and neuropathy development. Nonetheless, blood pressure control is another keystone in prevention and treatment, in addition to glycemic control. The significance of blood pressure control, irrespective of what agent is used, cannot be emphasized enough in diabetes, both for slow progression of neuropathy and for preventing cardiovascular morbidity. According to the recent Joint National Committee guidelines, blood pressure in diabetics is reduced to less than 130/80 mmHg. It is very crucial for doctors and patients to understand early on the 3 or more agents. Angiotensin receptor blockers or angiotensin-converting enzyme inhibitors are considered first-line agents in patients with concomitant hypertension and diabetes. Diuretics might be added as a second-line agent in many cases, after angiotensin blockade in diabetes. Dihydropyridines, a class of calcium channel blockers, may be considered as the third or fourth-line agents in diabetics, only after initiation of angiotensin blockade and diuretics. There are also other non-pharmaceutical suggestions, such as dietary restriction of protein intake, restrictions of protein to 0.8 grams per kilogram weight per day in patients with overt neuropathy, or even 0.6 grams per kilogram weight per day is recommended in the case of declining glomerular filtration ratio. Moreover, it is very essential to stick to a low-sodium diet in diabetic neuropathy, since many diabetics with renal disease are salt-sensitive. Therefore, restricting salt intake will certainly help in reaching blood pressure goals. with secondary benefits of regression of left ventricle hypertrophy, decreased stroke risk, and reduction in proteinuria. A recommended low-sodium diet of 2.3 grams daily in patients with diabetes and either hypertension or proteinuria. Moreover, avoiding nephrotoxin agents, such as radiocontrast media, nonsteroidal anti-inflammatory drugs, is highly recommended. Last but not least, annual diagnosis of microalbuminuria in diabetics will allow the detection of neuropathy at an early stage. Improved glycemic control and intensive anti-hypertensive treatment will ultimately slow down the progression of diabetic neuropathy.
Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello everyone. Now I'm going to explain to you something about pericarditis. The infection or inflammation that occurs in the pericardium is called pericarditis. Inflammation of the pericardial layers arises when the membrane gets thickened and the layers rub against each other. During such a condition, the increase in the fluid volume in the pericardial sac results in compression of the heart, which subsequently affects the functioning ability of the heart. Chest pain is the main symptom of pericarditis, which is normally not considered as a life-threatening condition, and patients may become normal in a few days or weeks. However, in certain cases, the symptoms may last for several months. It is a relatively common heart condition, and around 5% of patients with severe chest pain are diagnosed as pericarditis. Moreover, it is very common in men than in women. It affects people of all ages, but mostly occurs in young adults. Based on the symptoms and causes, pericarditis is categorized into many types. Pericarditis based on symptoms. Acute pericarditis occurs when chest pain develops suddenly, radiating to the neck, shoulders and back. The pain increases during when breathing in or inspiration and while lying down. However, it decreases while sitting. The symptoms may last for less than 3 months and may get resolved in a few days with appropriate treatment. Pericarditis may be idiopathic or due to viral or bacterial infection, cardiac arrest, metabolic disorders, or a blunt injury. The condition is also caused by radiation toxins, trauma, or as a side effect of certain drugs. Chronic pericarditis at times persists for a long period, and the symptoms last longer than 3 to 6 months. In such cases, the patient may not have the chest pain, but may experience tiredness, shortness of breath and coughing. Chronic pericarditis is believed to be the result of certain autoimmune disorders such as lupus, scleroderma, and rheumatoid arthritis, where the antibodies produced by the body attack its own cells and tissues. Pericarditis based on causes. Constrictive pericarditis occurs when the pericarditis is associated with a thickening or scarring of the pericardial layers. This starts constricting the heart within the thoracic cavity, which in turn controls its functioning. Pericardial effusion. In a normal individual, the pericardial cavity is filled with about 20 to 50 milliliters of fluid. At times, in patients with specific medical conditions such as severe hypothyroidism or kidney failure, or in patients who have undergone invasive cardiac procedures, there may be a gradual accumulation of fluid within the pericardial cavity, which may often be asymptomatic until the surrounding structures start getting compressed. In such cases, symptoms related to such compressions such as dyspnea, nausea, fullness of the abdomen may manifest. Cardiac tamponade is caused when persistent pericardial effusion causes the pericardial fluid volume to increase up to 80 milliliters or even 200 milliliters, which can lead to malfunction of the pericardium. Therefore, this condition has to be treated as an emergency. Viral pericarditis. Viruses that can cause viral pericarditis include Coxsackie viruses, influenza virus, agents of viral enteritis, human immunodeficiency virus, and echovirus. Upon onset of this condition, the early symptom can be the infection in the upper airways. This kind of pericarditis is simple and can be handled as an outpatient procedure. Purulent pericarditis is a rare disease caused by aerobic and anaerobic bacteria. Recent studies show that procedures such as surgery in the chest region, hemodialysis, immunosuppression, and chemotherapy are dominant causes that result in this type of pericarditis. Tuberculosis pericarditis is also seen in a very minor percentage of patients having pulmonary tuberculosis. HIV patients are at a high risk of tuberculosis pericarditis. There is a gradual progression of symptoms such as night sweats, dyspnea, fever, and chill, but any suspected patient should be given emergency treatment. Radiation pericarditis is caused due to recent mediastinal radiation at any time from weeks to months after the exposure. Malignancy pericarditis is mainly caused by metastatic disease. It is common in metastatized bronchogenic or breast carcinoma, Hodgkin's disease, and lymphoma. However, it is rare in primary mesothelioma and angiosarcoma. Traumatic pericarditis. Blunt or sharp trauma causes traumatic pericarditis. Invasive cardiac procedures may also cause this type of pericarditis, which includes cardiac diagnostic catheterization and electrophysiological ablation procedures.